Chapter 13, going over the shoulder joint. Please do not panic that your picture does not look the same on your first slide for your slideshow. My textbook picture got corrupted, and so I just put in a prettier picture because I like this better. Our shoulder joint, also known as our glenohumeral joint, is the articulation of the head of the humerus with the glenoid fossa for the scapula. It is a synovial joint, meaning it has a joint capsule, synovial membrane, synovial fluid, all of those things. It is a ball and socket joint. It has 3 degrees of freedom, making it a triaxial joint. And the shoulder is designed to have more mobility than it has stability. This is just a picture of the shoulder joint where we can see the humeral head articulating with the glenoid fossa. Motions that happen at the glenohumeral joint, we have flexion and extension in the sagittal plane about the frontal axis, so when the arm moves forwards or backwards. We have abduction and adduction in the frontal plane about the sagittal axis, so when our arm moves out to the side and then back down to the starting position. Medial and lateral rotation in the horizontal plane about the vertical axis, so moving the forearm in or out from the body when the elbow is flexed, and horizontal abduction and adduction in the horizontal plane about the vertical axis because the shoulder has to be positioned in 90 degrees of abduction to start this motion. We also have circumduction, which is a combination of shoulder motions where the arm moves in an arc of motion. Looking at the pictures here, so flexion, we have the arm moving forward up overhead. Extension, we have the arm moving back down to the starting position. Hyperextension for your textbook purposes of the shoulder is going to be where the arm moves back behind the body, but for clinical purposes, we will refer to this as shoulder extension. Lateral rotation, if we have the arm abducted to 90 degrees and the elbow flexed, is going to be when the palm is up facing out, and then medial rotation would be when the palm is down facing backwards. Horizontal abduction, when we have our arm abducted to 90 degrees, is going to be bringing the arm back behind the body. Horizontal adduction will be bringing the arm back in front of the body at 90 degrees of abduction. Abduction is bringing the arm out to the side and up overhead. Adduction is returning from that overhead position back down to the side. Circumduction is that combination of motions where we see that arc and that circle. And then scaption is where we move within the scapular plane. And if you'll remember from the shoulder girdle lecture, the scapular plane sits 30 degrees anterior to the frontal plane, and that would be overhead motions that happen in that scapular plane. Looking at normal range of motion values, these are clinical estimates. The norms are going to vary between the textbooks, so you want to know a normal range. If there's differences between resources, understanding that if the patient falls within the range of normal values, we can compare to the other side to see what the patient's normal is and determine from that if they fit within the normal range. For values that you need to know from your textbook, we look at 0 to 180 degrees of shoulder flexion and shoulder abduction. We have 60 degrees of shoulder extension, so starting from neutral at our side, moving backwards, we should have about 60 degrees. Medial rotation, we have 70 degrees. Lateral rotation, we have 90 degrees. Part of the reason there are restrictions to medial rotation is that the body gets in the way, so we have more room to move into external rotation or lateral rotation. For horizontal abduction and horizontal adduction, we have 30 degrees of abduction because we start aligned with the body. Moving backwards, we only have about 30 degrees of motion. But moving forward, we have 120 degrees where we can bring the arm straight out in front of us and then cross midline towards the other side of the body. And so that's where we get the 120 degrees of motion. Looking at the arthrokinematics of the shoulder joint, the surface area of the head of the humerus is greater than the surface area of the glenoid fossa, and that's part of why we need the scapulohumeral rhythm to maintain positioning of the glenoid fossa to support the humeral head. The head of the humerus is going to be our convex surface, the glenoid fossa is going to be our concave surface, and we see a roll, glide, and spin in this joint. We need to remember that most of our upper extremity motions are open chain motions, and so I believe your textbook only talks about them from an open chain motion. So looking at this chart here, flexion and extension in your textbook determines is a spin. However, clinically, we look at flexion and extension as having a roll and a glide. So for flexion, we would have an anterior roll and a posterior glide, and for extension, we would have a posterior roll with an anterior glide. The distal the glide is going to be in the opposite direction of the distal segment for all of our shoulder motions because we are looking at them in open chain where the convex surface is moving on the concave. So for abduction, we have a roll and a glide, where we have a superior roll and an inferior glide. Adduction, we would see an inferior roll and a superior glide. Medial rotation is going to have an anterior roll and a posterior glide. Lateral rotation will have a posterior roll and an anterior glide. Horizontal abduction is going to have a posterior roll and an anterior glide, and horizontal adduction is going to have an anterior roll and a posterior glide. So if we remember our scapulohumeral rhythm, we need to have scapular motion with humeral motion in order to achieve the full range of motion that we're looking for from the upper extremity. So when we see shoulder joint flexion, we also need to have upward rotation and protraction of the shoulder girdle. When we have shoulder joint extension, we need downward rotation and retraction and scapular tilt of the shoulder girdle. For abduction, we need upward rotation of the scapula. For adduction, we need downward rotation of the scapula. With medial rotation, we need protraction of the scapula, and lateral rotation requires retraction of the scapula. Horizontal abduction requires retraction of the scapula, and horizontal adduction requires protraction of the scapula. I would encourage all of you to go through the shoulder joint motions while trying to pay attention to your own scapular motions as you move the upper extremity so that you can see the connection between these. I would also advocate for you to ask somebody in your home or in class to perform the overhead motions with the upper extremity while you observe motion of the scapula, and maybe even put your hand on their scapula to feel the movement so that you can see the motions of the shoulder girdle as the shoulder joint moves to make the better connection between these things. Looking at our bony landmarks, so on the left side we have our posterior view where we can see our acromion process transition into our spine of the scapula that separates between our supraspinous fossa, so supra being above, spine being the spine of the scapula, fossa being a caving in or a small dip. So supraspinous fossa above the spine of the scapula, and then our infraspinous fossa below the spine of the scapula. Our supraspinous fossa is going to be where our supraspinatus comes from, and our infraspinous fossa is going to be where our infraspinatus comes from. Remember that our axillary border is the border closest to our axilla, so that's going to be the lateral border. And our vertebral border is the border closest to our vertebra, so that's going to be our medial border of the scapula. On the anterior aspect, we have our subscapular fossa, and this is where subscapularis comes from. And then we can still see our acromion process, we see our coracoid process on the anterior aspect, and then the labrum that surrounds the glenoid fossa. Looking at bony landmarks of the humerus, we have our humeral head, which is our articulation point, and that transitions into our anatomical neck, where that rounded portion starts to taper down. But that is different from our surgical neck, which is the transition from the larger rounded portion into the shaft of the bone. So the surgical neck is important for when we talk about total shoulder arthroplasties, because that's where the prosthetic is implemented. We have our greater tubercle, which sits on the lateral aspect of our humerus and is part of the impingement problem when we have impingement between our greater tubercle and our acromion process with overhead motion. Our lesser tubercle sits on the anterior aspect, both of which serve as attachment points for muscles. Our bicipital groove runs between the greater tubercle and the lesser tubercle, and that is where the long head tendon of the biceps runs before it blends into the joint capsule. Our deltoid tuberosity can be found more distal on the humerus for an insertion point for our deltoid. We can also look at our radius and ulna, but we're going to talk about these a little bit more in depth when we get down to the elbow and forearm. But we've got the head of the radius and the radial tuberosity. Radial tuberosity is going to be where our biceps attaches to. And then our radial styloid process, which we know how to palpate so that we can find our brachioradialis reflex. So we have all these bony parts that need to be connected by soft tissue structures, and we are going to talk about them. So our glenoid labrum is going to be the fibrocartilaginous ring that surrounds the glenoid fossa and attaches to the rim of the glenoid fossa, helps to deepen the fossa and increase stability of the joint. We also have several bursa around our shoulder joint. So our subdeltoid bursa runs between the deltoid muscle and the joint capsule to help reduce friction of the deltoid muscle rubbing on the joint capsule. And our subacromial bursa is between the acromion and the coracoacromial ligament, again serving to reduce friction. When we have irritation of either of these bursas, we can have difficulty with overhead motions and pain with shoulder movement. Here's just a picture to help highlight the glenoid labrum surrounding the glenoid fossa. The ligaments of the shoulder, we have our glenohumeral ligaments that help to reinforce the joint capsule and sit on the anterior aspect of the joint. There are three portions to the glenohumeral ligament: our superior, which runs from the supraglenoid tubercle and the humerus near the tip of the lesser tubercle. Our middle glenohumeral ligament runs below the superior glenohumeral ligament along the anterior glenoid margin and lesser tubercle. And the inferior glenohumeral ligament runs from the anterior and posterior aspects of the glenoid fossa and the medial aspects of the neck of the humerus. The coracohumeral ligament, so coraco being coracoid and humeral being humerus, it goes from the dorsal lateral side of the coracoid process to attach to the greater and lesser tubercles of the humerus. The transverse humeral ligament attaches to the lips of the bicipital groove and helps to keep the long head of the biceps in place. We can look at some pictures of these here. So our glenohumeral ligaments we can see in the anterior aspect of the shoulder joint, and we see our capsule above and below it. Our glenohumeral ligaments run with our joint capsule, so it's not like there's a gap in there, but our glenohumeral ligaments are just over top of it to help reinforce the joint capsule. We can see the tendon of the long head of the biceps come up through the bicipital groove and where it would need covered as it goes and blends into the joint capsule. And then we can see our coracohumeral ligament attaching from our coracoid process over to our humerus. And I believe that's all you can really visualize in this picture. Just another visual to give you understanding of how the coracohumeral ligament comes in on top of the joint capsule. Joint characteristics. So we talked about sternoclavicular joint characteristics in the shoulder girdle lecture. This kind of helps just create a correlation and help you understand how those joint characteristics evolve through joints. So for the shoulder, we're looking at the closed pack position, so where we have the most bony approximation, being the position of full abduction and external rotation. The loose pack position, so where we have the least bony approximation and the most movement that we can provide for accessory motions within the joint when we're applying mobilizations, is going to be 30 to 60 degrees of horizontal abduction with 30 to 60 degrees of flexion. The shoulder should have a firm end feel in most of the directions. I would say horizontal adduction being the potential difference there because of soft tissue approximation being a potential limiting factor to range. And our capsular pattern, so if the patient has a restriction in joint motion due to restriction in the capsule, we're going to see loss of external rotation greater than abduction, which is going to be greater than internal rotation, and we'll see them happen in that order. The most vulnerable position of the shoulder is 90 degrees of abduction with full external rotation. So that's going to cause the anterior joint capsule to be taut and have limited support of the humeral head on the glenoid fossa. So this is the position that the shoulder is most vulnerable to dislocation in. And we can think about this, a common way to dislocate the shoulder is a quarterback up in the throwing position, takes a hit to the arm, causing that anterior dislocation. So if we think about bringing our arm up into 90 degrees of abduction and full external rotation, that's going to get us loaded for a throwing motion, and that position creates vulnerability to that anterior shoulder dislocation. Breaking movements down by the muscles of the shoulder, shoulder flexion is going to be caused by anterior delt coracobrachialis and the clavicular portion of pec major. Extension will be caused by the posterior delt, the lat, the teres major, and the sternal portion of pec major. Abduction will be caused by our delt and our supraspinatus. Adduction is going to be caused by pec major, teres major, and the lat. Horizontal abduction is caused by our posterior delt, our infraspinatus, and our teres minor. Horizontal adduction is caused by our anterior delt and our pec major. External rotation is caused by infraspinatus, teres minor, and the posterior delt. And internal rotation is caused by our lat, teres major, subscapularis, pec major, and anterior delt. Special muscles of the shoulder are going to include our rotator cuff, which are designed to provide stability to keep the humeral head sitting in the glenoid fossa. They form a tendinous band of a cuff around the head of the humerus to help maintain the joint integrity. It maintains the head of the humerus in the glenoid fossa to provide stabilization, and we refer to our rotator cuff muscles as sits muscles because of the mnemonic for their name, because it's easy to remember them. So our sits muscles are going to include our supraspinatus, infraspinatus, teres minor, and supraspinatus. I'm sorry. I said that backwards from what's written on here. I would put supraspinatus first because of mnemonic purposes. So supraspinatus, infraspinatus, teres minor, and subscapularis are the 4 muscles to your rotator cuff. I would just list them in a different order than I have on this PowerPoint. So we can see the muscle bellies here of supraspinatus, infraspinatus, teres minor, and subscapularis, and how they come to wrap around the humeral head, but I think the next picture shows it better. So this just highlights how those tendons come around and where the head is, and you can see it just creates this cuff that pulls that head of the humerus into the glenoid fossa to improve stability. The shoulder joint also involves the thoracolumbar fascia, which is a fibrous sheet superficial to the sacrospinalis muscles that fans out for this large origin for our latissimus dorsi. It attaches to the spinous processes of our lower thoracic and lumbar vertebra and the supraspinal ligament, posterior portion of the iliac crest, and sacrum. So that spans a pretty large region, and you can understand how it fans out coming from the spine out to the pelvis. And again, it serves as the origin for the latissimus dorsi muscle. Our nerves of the shoulder joint all break off from our brachial plexus. So we have our 5 major nerves of our brachial plexus are going to include our axillary, musculocutaneous, radial, ulnar, and median nerve. Looking here, we have our axillary nerve running from C5, C6 nerve roots, and it goes to innervate the teres minor and the deltoid. Our musculocutaneous nerve comes from our C5, C6, C7 nerve roots, and it goes to innervate our coracobrachialis and our biceps brachii and our brachialis. Jumping into muscles, our deltoid is a superficial muscle of the shoulder that is broken into 3 functional portions, our anterior delt, middle delt, and posterior delt. Our anterior delt originates on the lateral third of the clavicle to insert on the deltoid tuberosity. It causes shoulder abduction, flexion, medial rotation, and horizontal adduction in open chain motions. And in closed chain motions, it causes depression of the shoulder girdle when the humerus is stabilized. It is innervated by the axillary nerve. Our middle deltoid originates from the acromion process, also inserts on the deltoid tuberosity, and causes shoulder abduction in open chain motions. When the humerus is fixed, it causes depression of the shoulder girdle and is also innervated by the axillary nerve. And our posterior delt originates on the spine of the scapula to again insert on the deltoid tuberosity. It causes shoulder abduction, extension, lateral rotation, and horizontal abduction. But when the humerus is fixed, it causes depression of the shoulder girdle. It is also innervated by the axillary nerve. Our biceps brachii is more commonly known as an elbow flexor, but because the long head of the biceps crosses the shoulder joint, it also contributes to shoulder flexion. So we talk about it here with the shoulder joint. Remember, the long head of the biceps, also the tendon, goes into the bicipital groove and blends into the joint capsule of the shoulder. The origin of the long head is the supraglenoid tubercle of the scapula, and the origin of the short head is the coracoid process of the scapula. They both insert on the radial tuberosity of the radius. They cause shoulder flexion, elbow flexion, and forearm supination, and are innervated by the musculocutaneous nerve. Our coracobrachialis muscle is nicely named because it runs from the coracoid process to our arm, which is brachii. It is an important muscle in helping the rotator cuff provide shoulder stability. It is a small muscle, but you can see how it comes from a different direction than our rotator cuff muscles, and so can help to provide the support that the shoulder needs because it has more mobility than it does stability. Our coracobrachialis originates on the coracoid process of the scapula to insert on the medial surface of the humerus near the midpoint. It causes shoulder flexion and adduction and also helps to stabilize the shoulder. It's innervated by the musculocutaneous nerve. Pectoralis major is an anterior shoulder muscle, and we can see here that we have a sternal portion which attaches to the sternum and a clavicular portion which attaches to the clavicle. The origin of pectoralis major is the medial third of the clavicle and for our clavicular portion, and it inserts on the lateral lip of the bicipital groove of the humerus inferior to the sternal portion. So these muscles cross each other. So we have a more superior origin for our clavicular portion with a more inferior insertion compared to our sternal head that has a more inferior origin and superior insertion. The clavicular portion of pectoralis major causes shoulder flexion in the first 60 degrees, medial rotation, and adduction. And it also can cause horizontal adduction. It is innervated by the lateral and medial pectoral nerves. Pectoralis major, the sternal portion, comes from the sternum, the costal cartilages of the first 6 ribs, and inserts on the lateral lip of the bicipital groove of the humerus superior to the clavicular portion. So if you remember, I talked about how those cross. We've got one starting high and inserting low. The sternal portion starts low and inserts high. It causes medial rotation, adduction, and horizontal adduction. When we are moving from full shoulder flexion, it also contributes to shoulder extension when shoulder extension is resisted. So when we are trying to pull against resistance into shoulder extension and we are not having gravity assist with the motion, the sternal portion of pec major is contributing to this. And so I like to think of this muscle as our wood chopping muscles. We need our pec major, the sternal portion of our pec major, in order to bring an axe from overhead in our fully flexed shoulder position to down chopping with a forceful motion into shoulder extension. When the upper extremities are stabilized, the sternal portion of pec major also contributes to elevate the body, and it is innervated by the lateral and medial pectoral nerves. Latissimus dorsi, also known as our lats, originates via the thoracolumbar fascia that we talked about that kind of fans out, and you can see in this picture how that fans out from the central spine all the way out to the pelvis. So we have a very large origin to our lats. So that attaches to the spinous processes of T7 through L5 and the posterior surface of the iliac crest and the sacrum and the lower 3 ribs. It inserts on the floor of the bicipital groove, so it goes underneath of that biceps tendon to sit on the floor of that groove. It causes shoulder extension, adduction, and medial rotation, so I like to refer to it as the handcuff muscle, because if you were to put yourself in the position of being handcuffed, you have shoulder extension, adduction, and medial rotation. When the upper extremities are fixed, the lats elevate the body, and they are a big, important muscle for de-weighting the pelvis when we're trying to shift in bed for bed mobility, and they are a big muscle in raising the body for crutch walking or utilizing a walker, especially when we have a non-weight bearing status. The lats are innervated by the thoracodorsal nerve. Running deep to the lats, we have teres major, which is an inferior muscle of the shoulder. It originates from the inferior axillary border of the scapula near the inferior angle to insert on the medial lip of the bicipital groove. So it has that kind of upward line of pull, causing shoulder extension, adduction, and medial rotation, similar to what our lats cause, but our lats are a bigger contributor to those motions. And it is innervated by the lower subscapular nerve. Triceps brachii. Again, we think of triceps as more of an elbow muscle, but because we have heads that cross the shoulder, it also contributes to shoulder motion, and so we look at it in both places. The long head of the triceps originates on the infraglenoid tubercle of the scapula. The lateral head originates inferior to the greater tubercle on the posterior humerus, and the medial head originates on the posterior surface of the humerus. So only our long head crosses the shoulder. They all insert on the olecranon process of the ulna and cause shoulder extension and elbow extension. And the triceps is innervated by the radial nerve because the radial nerve runs on the posterior aspect of the upper extremity. Supraspinatus is one of our rotator cuff muscles. Remember, supra being above spine, spine of the scapula. So supraspinatus sits in our supraspinous fossa, and that's where it originates from, to insert on the greater tubercle of the humerus. Supraspinatus causes shoulder abduction and stabilizes the shoulder. So when we get into lab, we can palpate supraspinatus muscle activation by thinking about abducting the shoulder. And the supraspinatus is innervated by the suprascapular nerve. Infraspinatus is another one of our rotator cuff muscles. Remember, infra being below spine, spine of the scapula. So its origin is the infraspinous fossa of the scapula to insert on the greater tubercle of the humerus. It causes shoulder external rotation and horizontal abduction, but again, the primary role of our rotator cuff muscles is to stabilize the shoulder, and it is innervated by the suprascapular nerve. Teres minor is another one of our rotator cuff muscles. It sits just below infraspinatus but above teres major. Its origin is on the axillary border of the scapula to insert on the greater tubercle of the humerus. It causes shoulder external rotation and horizontal abduction. And again, it's a rotator cuff muscle, so it has an important job in stabilizing the shoulder. Teres minor is innervated by the axillary nerve. Subscapularis is the last of our rotator cuff muscles. It sits on the anterior aspect of the scapula to wrap around. So its origin is the subscapular fossa, so sub being below the scapula, it's underneath. It inserts on the lesser tubercle of the humerus, so it causes shoulder adduction and internal rotation. It is going to be one of our prime contributors to internal rotation. Again, being a rotator cuff muscle, its primary job is to stabilize the shoulder, and it is innervated by the upper and lower subscapular nerves. And this is just a review of the same slide that we had earlier where we talk about the motions of the shoulder and what muscles cause them. Some things that I want you to pay close attention to now that we've gone through those muscles is understanding how the clavicular portion of pec major contributes to shoulder flexion, but the sternal portion contributes to shoulder extension, and how they cross and they're changing in line of pull causes those difference in muscle actions. And then I also want you to see here I have highlighted where our rotator cuff muscles contribute to motion. Though the primary role of the rotator cuff muscles is to stabilize the shoulder, they do contribute to our motion as well. Looking from the anterior aspect of the shoulder, we can see on the left side our superficial muscles that can include pec major, our delt, and our biceps. And then deeper to that, we have our biceps. Still, we can see where it runs underneath some of those more superficial muscles. We have our coracobrachialis and our subscapularis and our latissimus dorsi that we can see from the anterior aspect, and we can kind of see teres major poking through there. From the posterior aspect, again on the left, we have our superficial muscles. We see our deltoid, our latissimus dorsi, and the thoracolumbar fascia for its origin. And then on our deeper side, we can see where our lat runs, and then underneath we have teres minor, infraspinatus, supraspinatus. We can't see subscapularis from this direction because it sits on the anterior aspect. In order to have good shoulder abduction, we have to have a force couple between our deltoid and our supraspinatus. And so this is what we're talking about in this picture here. If the deltoid muscle were acting alone, we would have superior movement of the humerus compressing the articular space and not allowing for the roll and glide that we need for abduction. But when the rotator cuff muscles, specifically supraspinatus, work with the deltoid, we have a greater rotary motion, and so movement isn't lost through the length of the bone, but instead causes the rotation that we need for abduction movement. So we talked about crutch walking in the shoulder girdle chapter, where we have serratus anterior and pec minor that contribute to stabilization and elevation of the thoracic cage. But looking at our shoulder joint muscles, we have pec major and latissimus dorsi that also contribute. So our arms are stabilized by weight bearing on the crutch handles, making them fixed in a closed chain motion so that we have movement of the thoracic cage, including the shoulder girdle. The contributions from serratus anterior and pec minor help to further stabilize the scapula and elevate the trunk, but pec major and latissimus dorsi are bigger muscles for the actual elevation of the trunk. Now that we understand the anatomy of the shoulder joint and how the motions happen, we will look at common pathologies that we can treat in therapy. Shoulder subluxation is going to be excessive glide of the head of the humerus and the glenoid fossa. So remember, that's that partial dislocation that we talked about, where the head of the humerus isn't completely out of the glenoid fossa, but it's also not sitting where it's supposed to. Shoulder dislocation is total loss of joint integrity. I'm sorry, loss is missing from that sentence there. But that's where we see the humeral head completely slip from the glenoid fossa, and usually there's disruption to the joint capsule and the surrounding ligaments as a result of that because the integrity of the joint has been disrupted. We can also see fractures where we see fractures of the neck of the humerus as a result of Fuchs injuries or a fall on an outstretched hand. Mid-humeral fractures are caused by twisting forces. So if somebody's arm is grabbed and twisted, that can be a cause of a mid-humeral fracture. And it's important for us to know that the radial nerve runs in that radial groove at the mid-humerus, and so we have a risk of radial nerve injury when there's a mid-humeral fracture. Pathological fractures can also occur in the humerus as a result of loss of bone density and trying to utilize too much muscular strength where the muscle pulls on the bone adversely, causing a pathological fracture. We'll look at impingement syndrome, which happens between the acromial arch and the head of the humerus. And this is typically due to a loss in the scapulohumeral rhythm. And we get impingement between the greater tubercle and the acromion process of our rotator cuff muscles, with supraspinatus being the most commonly involved. Adhesive capsulitis is also known as frozen shoulder. It is inflammation of the joint capsule, but it's also adhesion of the joint capsule that restricts motion. A torn rotator cuff, it identifies which muscle of the rotator cuff muscles is involved. Again, supraspinatus is going to be our most commonly involved because of the risk of impingement, and so those micro tears over time result in tearing of the tendon. But a torn rotator cuff can be any of our sits muscles, and we have to identify which muscle is involved to determine the appropriate rehab and recovery. Labral tears of the shoulder can decrease joint integrity because that fibrocartilaginous ring is helping to support shoulder stability by increasing the depth of the glenoid fossa and promoting improved bony articulation. And so when we have a tear in that structure, the congruency is lost, and so we lose support. Biceps brachii tendinitis is going to be inflammation of the long head of the biceps. Again, crossing the shoulders, the long head of the biceps, and blending into the shoulder capsule. And so when we have inflammation in that joint, we can have restrictions to range of motion and limitations to strength. Before class, I want you guys to review the shoulder joint anatomy that was discussed in this lecture. Use your flashcards, do whatever you need to. But review all that stuff to prepare for range of motion and manual muscle testing of the shoulder joint in lab. Write down any questions you have over the chapter to discuss in class before we begin our lab activity, and make sure that you prepare lab-appropriate clothing to expose and test the shoulder joint.